Bismillahirrahmanirrahim. My name is Dr. Sarah, and the topic which we are discussing is nutrient and associated diseases. Alhamdulillah, we have covered the major chunk of this topic before in our previous lectures, and we have discussed about the nutrients, about the balanced diet. I will just go through the slides because we have already covered it and you must be knowing about this. These are some dietary reference intakes terminologies and you must know these. Uh, there are two categories of nutrients, macro and micro. Water, of course, the forgotten nutrient. So we have also studied some facts about water, what are the energy requirements in us, and then the food content, the energy content of the food, how energy is used in our body, some terminologies like resting metabolic rate, and then the factors affecting the resting metabolic rate. We have discussed them all. Uh, then we also have discussed about the energy in different physical activities. Then we have covered the major food groups, the available carbohydrates types, fiber, then the very important topic glycemic index. We have already covered them, dietary fats, some important definitions regarding tags, saturated and unsaturated fats. It's a very favorite topic of examiners in the Viva. Then there are some deficiency states. The Mediterranean diet, proteins, then nitrogen balance. Okay, so the topic of today, which we are going to discuss, is nutrients associated diseases, and we have also uh, discussed about some parameters of these before. Obesity will be covered in our next lecture. Today we are going to discuss this protein energy malnutrition. All of these slides they are taken by the Lippincott. You can easily access them from there. And so, what is protein energy malnutrition? It is the most important form of malnutrition, and there are two types of it. One is Kwashiorkor, and the other is marasmus. In what happens in protein energy malnutrition is it occurs in highly catabolic patients and malnourished elderly patients or children. So, what is Kwashiorkor? In Kwashiorkor, there is extreme protein deficiency. So, it can occur in infancy and it is used to describe the sickness of weaning. Maximal incidence is in the second year of life following abrupt weaning. And the term marasmus, it is derived from the Greek word marasmos, which means wasting. And marasmus involves inadequate intake of protein and calories and is characterized by emaciation. Marasmus represents the end result of starvation where both proteins and calories are deficient. So in Kwashiorkor, protein deficiency often associated with leaning into thin cereal gruels, and their typical symptoms are stunted growth, edema due to lack of plasma proteins, skin lesions, depigmented hair, anorexia, and large fatty liver, and decreased albumin levels. In marasmus, there is calorie deficiency because of lack of food, poorest populations, neglected infants and children. It results in wasting, that is, the deterioration of tissues, and also the brain development is impaired. Its typical symptoms are arrested growth, stunt growth, extreme muscle wasting, weakness, and anemia. So, this is a table which actually differentiates between marasmus and Kwashiorkor. I Strongly recommend you to go through this the differentiation chart, and you must remember these points because it is a very important UQ. It is a pictorial description of Erasmus and Kwashiorkor core. And this is a general overview of protein energy malnutrition that the majority of rural children live in developing countries. Their lack of food and clean water, poor sanitation, infection, and social unrest lead to low birth weight and protein energy malnutrition. Malnutrition is implicated in more than 50% of deaths of less than 5-year children. This is the ugly face of hidden hunger. There are some other micronutrient malnutrition, that is deficiency in vitamin A, iodine, iron, zinc, calcium, vitamin D, B vitamins, and vitamin C. In vitamin A deficiency, you must be knowing that the half of these children which have vitamin A deficiency, they die within a year of becoming blind, and this condition is called xerophthalmia, and they have the diet lacking green vegetables. Iodine deficiency affects 740 million people worldwide. It is the single greatest cause of preventable brain damage in babies, goiter, stillbirth, miscarriages, mental retardation, and it is prevented by iodized salt. Iron deficiency anemia, it affects 2 billion people and 90% live in developing countries. 39% occurs in preschool children, 50% in pregnant women. High iron rice could help. Other deficiencies are these: zinc, vitamin C, niacin, thiamine, calcium, vitamin D, and folate. In zinc, there is growth retardation, delayed sexual maturation, skin and eye lesion, and 48% of world at risk for zinc deficiency. In calcium deficiency, there is osteoporosis with eventual bone loss. In vitamin D deficiency, there is rickets, which is bone malformation. In vitamin C deficiency, scurvy occurs, and it is a very significant problem in refugee camps. So in niacin deficiency, there is pellagra, that is the dermatitis, diarrhea, and dementia, and due to diet high in maize, which is low in tryptophan. In thiamine deficiency, it causes beriberi, and it is due to a diet high in polished rice. In folate deficiency, there are birth defects in encephaly and spina bifida. So, in the end, we say that the nutrition matters. Uh, we have completed this topic, and inshallah, we will be having a revision lecture of this whole topic in the coming week. Uh, that's all. Thank you. Allah Hafiz.